This podcast is intended as healthcare practitioner education only and is not a substitute for medical advice, diagnosis, or treatment.
Genes involved in autoimmune conditions can be triggers for those thyroid autoimmune conditions as well. So I think there's, that sort of sets the stage there. And then there's some sort of a trigger, whether it's a virus, poor diet, gluten exposure, low nutrients, gut health stress, any one trigger. Then we start to see that immune cell infiltration of the thyroid gland, causing inflammation. It's that inflammatory response that the thyroid cells start to be attacked. And the immune system can start making low levels of antibodies at this stage.
The earlier we can pick it up, then we can address the factors and just keep things at bay and start to improve things. Because if that's left over months and years, it can get to a point where there's been enough atrophy of the thyroid gland, there's enough destruction of the thyroid gland, such that then, yes, people will probably need to take thyroxine and or T3. Whereas if you pick it up in the earlier stages, we've got a chance to really say, okay, where's this inflammation and oxidative stress coming from?
So after the birth of my daughter, I was very, very anxious. I was hot all the time. I was losing a lot of weight and just didn't feel right. But sort of, I think having a newborn and being, really OCD, probably I just dismissed the symptoms. And it wasn't until I went in to see my doctor with a skin rash on my face that she said, "You look really unwell. You just look really unwell and let's get some blood tests done." And that's when I got diagnosed with Graves' disease.
This is Bioconcepts Between Clinical Minds, the podcast that's open-minded enough to take in all sides of a clinical story. You'll hear from researchers, doctors, naturopaths, nutritionists and patients. We look at common clinical presentations through a different lens. It's open, frank and sometimes controversial. Nothing is off limits. Will it change the way you treat? We'll leave that up to you. In Season 3 of Bioconcepts Between Clinical Minds, we look at thyroid health. We talk to experts in the field who will take you into their clinics and share their experience. I'm Tony Chambers, and this is Bioconcepts Between Clinical Minds. In this episode of Between Clinical Minds, we discuss autoimmune thyroid conditions with specialist thyroid naturopath Tara Nelson, integrative GP Dr Ameeta Gajjar, and Graves' disease patient Byron Pugh. Tara Nelson is well known in the naturopathic community for her thyroid specialisation. She has Hashimoto's herself and says thyroid conditions, including autoimmune presentations, have been on the rise. She says it's important that clinicians are able to interpret the different antibodies.
They're a diagnostic measure of thyroid autoimmune conditions. But just keeping in mind that people can have, say, Hashimoto's without sort of any antibodies. We can have seronegative antibodies, but also, people can have antibodies without clinical sort of manifestations. So that's sort of, the scene there. But for me, the antibodies will diagnose a thyroid autoimmune, and it will let us know from, it'll enhance our treatment response in, are we treating hypothyroidism or are we treating autoimmune Hashimoto's? Are we treating hypothyroidism or are we treating Graves' disease? And obviously our treatment response is going to be very different for those two conditions. Again, recognition of those antibodies doesn't really generate a direct intervention, but they allow us to predict that clinical sort of outcome there. So it's going to distinguish those two things. So our TRAB antibodies, our thyroid peroxidase antibodies, are present in the majority, so around about 85% of Hashimoto's and up to about 70% of Graves' disease. So it is really important to test all three antibodies in pretty much all thyroid patients, because all three antibodies, our TPO, our thyroglobulin, and our TRABs, can exist across the board in Hashimoto's and Graves' disease. So I guess TRAB are considered diagnostic for Hashimoto's. And if there aren't any sort of clinical manifestations, so if we see antibodies but they haven't yet affected the thyroid gland, then that can implicate that they may have a risk of developing an autoimmune condition in the future. Also, TRAB will increase the risk of postpartum thyroiditis. So the presence of thyroid antibodies during the first trimester is associated with a probability for up to 52% for developing postpartum thyroiditis. So if they're detected in pregnancy, they are at that risk. And also those TPO antibodies can increase the risk of miscarriage, so recurrent abortion there. We know that the aging process increases the risk of those antibodies, and I see that often too in my postmenopausal women. They'll quite often have antibodies. They might not have sort of clinical manifestations of those antibodies. We also see a higher TSH as women age as well. Up to 50% of women with a first-degree relative with autoimmune thyroid disease and 30% of men suggest this dominant inheritance pattern. So that it can also suggest that there's runs in that familial line, and they may be at risk of developing an autoimmune thyroid condition in the future also. So TRAB are mainly used with TPO in the presence of Hashimoto's. So they're found in around 50 to 90% of patients with Hashimoto's, less frequently in Graves', but they do exist up to about 50%. But TRAB are also present in our differentiated thyroid cancer patients also. So they can be a way of detecting TRAB, particularly without the presence of TPO, so quite significantly higher than TPO. I always suggest that my patients go and have an ultrasound to rule out thyroid nodules and also rule out particularly differentiated thyroid cancers. And also TRAB, TRAB, thyroglobulin I'm talking about here, not TRAB. So our thyroglobulin antibodies can be used in the follow-up of our patients with differentiated thyroid cancers. So, they're used as that diagnosis, and then once they've had treatment for those cancers, thyroglobulin antibodies will be tested regularly to make sure that they've come down also. And then our TSH receptor antibodies, our TRAB antibodies, are found in around 90% of Graves' and up to about 20% in Hashimoto's, and also up to about 75% in a condition called atrophic thyroiditis. And they're more to do with our thyroid blocking antibodies. So under that TRAB umbrella, we have our TSI, or our TSH stimulating immunoglobulin antibodies, and they are the antibodies that will actually attack the TSH receptor, inducing hypothyroidism. Okay, so when we're seeing high TSI antibodies in Graves', then we know that's, and then we see that concurrent hypothyroidism, it's that antibody causing that, rather than say a toxic or hot nodule causing hypothyroidism. Now our TB, or our thyroid blocking antibodies, are fairly a new concept. As far as I'm aware, they're not actually tested in Australia as yet. I know in the United States and in the UK, they're tested in laboratories there, and they can cause a hypothyroidism in, say, a Graves' patient. So they are present also in Hashimoto's and Graves', and they can cause a transient hypothyroidism or a more severe atrophic thyroiditis. So I'm always thinking of the TB or thyroid blocking antibodies in, say, a Hashimoto's patient that we've worked on really well. They're taking thyroxine, but they're just not improving. They're not. It looks like their T4 from taking thyroxine is very good, but they're just not improving. And then I'll usually on ultrasound we'll see that thyroid gland is really fibrotic or very small, or it's actually atrophied. And so we can, because we don't have the testing, we can assume that they've had those thyroid blocking antibodies that's really caused a lot of atrophy to their gland. And these patients generally will need T3 because they just don't do well. And we'll talk about, why maybe they don't do well a little bit down the track. But so they're the main antibodies, and so that's why we test them in many of our thyroid patients.
And you did mention that often the antibodies will be raised without any clinical symptoms. So given that the medical profession will only test for TSH,
Yes.
if a patient presents, which ones do you kind of do as a matter of course? And then when you've got those results, you'll do others, or will you just do all of them at once?
All of them at once. I mean, if you look at the medical algorithm, they are very much let's just TSH, and we'll wait till that either gets high or low before we move on to something else. Or T4 is probably tested because if they're on thyroxine, so they want to make sure that their level of thyroxine is right for that patient. But that's going to miss so many cases of early cases of autoimmune disease. And as we're going to go in through the stages of autoimmunity a bit later on, we can see that the presence of those antibodies over time, particularly the TPOs, causes a lot of inflammation, lymphocytic infiltration, and they will end up, that inflammatory response will end up destroying those thyrocytes over time, causing hypothyroidism. So we know the biggest driver, the biggest cause of hypo and hyperthyroidism is antibodies that actually they're causing that condition in the body. So I believe it's really important. And now with my knowledge of the thyroid blocking antibodies and that TSI and TRAbs can be present in Hashimoto's just as much as our TPO antibodies can be present with our Graves' disease, I think it's really important to have that knowledge. So I like the full thyroid panel. I like all 3 antibodies. If I can get them, I usually rely on naturopath because I'm going to get everything there to do an extensive thyroid panel. If the doctors are not going to do it. And a thyroid ultrasound is going to give us so much information about the health of that gland too. And I think as physicians, I think we're going to miss so much if we don't have that information. I just have to have all that information so I can really make that a really good clinical judgment about where we're going to go to now and what's going to happen with that patient. And particularly when you've seen, if you're doing all of the things to support that hypo-Hashi patient, and if they've got an atrophic thyroiditis, they need T3. They just do, because there's not much that we're going to do to support that tissue anymore. It's gone. It's literally gone.
And once someone gets to have an atrophic thyroiditis, are there things that we can do? Like, is it able to be managed?
Well, if it's caught early enough, and the things with the thyroid blocking antibodies, people can flip from TSI to TB quite readily. So if it's a transient, then that's okay. We can pick that up. We can support it. But if it's not picked up for a long time, then it can cause damage. And once they've got that thyroid atrophy, look, it takes a lot for it to really come back. There is research around thyroid cells growing back and tissue, regenerating, but it takes a lot. It really does. When that thyroid gland is it's almost like it's fibrotic, it's shriveled, it's atrophied. It's really hard to stimulate that back to working.
So can we please go through the stages of thyroid autoimmunity?
Well, I guess the first stage is that sort of genetic predisposition. So looking at the family history, particularly that maternal line for women, so grandparents, mothers, aunties, on that maternal line. Also with a thyroid autoimmune condition, but also other autoimmune conditions. So we know that a lot of other autoimmune conditions, such as celiac, type 1 diabetes, vitiligo, for example, can coexist with our thyroid autoimmune. And those genetics, genes involved in autoimmune conditions can be triggers for those thyroid autoimmune conditions as well. So I think there's, that sort of sets the stage there. And then there's some sort of a trigger, whether it's a virus, poor diet, gluten exposure, low nutrients, gut health stress, any one trigger, then we start to see that immune cell infiltration of the thyroid gland causing inflammation. It's that inflammatory response that the thyroid cells start to be attacked. And the immune system can start making low levels of antibodies at this stage. Patients at this stage may not have any symptoms at all. And usually, if the immune system is healthy, it's working well, it will counterattack this. It'll be working really hard to counterattack that sort of, immune cell infiltration. And this stage can go on for decades before enough damage is done, before we see the next stage as subclinical hypo. So TFTs at this stage often remain normal. There might be a slight presence, just raised of the antibodies there. But if that person's healthy, there's not a lot of other, systemic inflammation or other things going on in the body, then the immune system might sort of, counteract. It'll all be fine. But if not, then we move on to the next stage, which is a subclinical hypothyroidism, where over time we're seeing that degradation of the gland. If we're talking hypo, then TSH may rise. Subclinical hypothyroidism is characterised anywhere from a TSH from 3 to 10, but with sort of normal T4 and T3 at that stage. Mm-hmm. So antibodies may increase a little bit as well. Again, some individuals may be, continue to be antibody negative also. But we're seeing also as the TSH rises, we know TSH is that whip. It continually whips the gland, and we see more inflammation of that gland and destruction of those thyrocytes. So again, as this continues on, the antibodies continue to rise. We see, more and more inflammation and that lymphocytic infiltration. They start to have thyroid failure. So we're seeing a, primary hypothyroidism where we're seeing TSH, continually, whipping the gland, and we start to see those low T4 and T3. At this stage, some people, struggle to make thyroid hormones, so that this might be the stage where they're put on a T4 preparation, some sort of thyroxine or T4 derivative. And then, if this is not treated or that autoimmune attack just keeps going on, we start to see then progression to other autoimmune diseases, and that's that sort of end stage where, celiac, Sjögren's, psoriasis, rheumatoid, any number of that autoimmune diseases can sort of come from there. So that's sort of in a nutshell, very much in a nutshell what would happen.
Yeah. And what about the long-term impact of the body in terms of developing other conditions such as thyroid cancer? So the long-term impact of autoimmunity, obviously.
Well, autoimmunity can be one of the drivers of thyroid cancer. So we see thyroid cancer developing in a nodule. So nodules develop within the thyroid. Autoimmunity definitely is one of the drivers, but there are many, many more. Low iodine, past exposures of radiation, particularly in childhood, insulin resistance, inflammation. There's a lot of, drivers of nodule development, and then the movement or the progression onto thyroid cancer. But antibodies can be one cause of that, but there are many more there for sure.
So the development of other autoimmune conditions is a more likely outcome or long-term impact, is it?
It can be, yes. Yeah, and just more and more reliance on that medication. And, as we see, and I see in clinic, and we're going to talk about sort of advances as well, is that, T4 therapy relying on T4 of that thyroid gland is just, there's not a lot of active tissue to produce. It's really struggling to make its thyroid hormones. There is that reliance on T4. Those patients need to make sure that they're converting that T4 to T3, and T3 can actually get up into the cell. I see, many patients that really struggle with T4 monotherapy. They still have all of the symptoms. They've been on T4 for years because they've been diagnosed with, say, Hashimoto's many years ago, and they come in to see me still struggling, if not more, with the same sort of symptoms. So there's definitely a subclass, and I think it's more than the research shows that just, don't do well with T4 alone. So then we can see sort of long-term impacts. There can be cardiovascular. We often see, high cholesterol. We see non-alcoholic fatty liver syndrome. We see, many sort of bone osteoporosis. Long-term stages of that are really, I think, low thyroid hormones. And then I guess, too, if that autoimmunity is, if you've still got all the drivers and triggers and they haven't been addressed, and you've got those right sort of genetic predisposition, we can see more and more autoimmune It's almost like I see in some patients, they just have a real autoimmune tendency. Not all of them do, even though they may have positive antibodies, but some just seem to just be, have that genetics. I think the underlying driver is those genes that predispose them to more and more autoimmune conditions. So we can see, my Hashimoto's patients, even Graves' patients, come in with, a couple other autoimmune conditions alongside it as well.
Dr Ameeta Gajjar is an integrative GP based in Sydney, and she orders a full thyroid panel to ensure nothing is missed.
In conventional medicine, the thinking is, well, if it's hypothyroidism, it's thyroxine, that's it. There's nothing else that can be done about it. And I'm still hearing those stories. And the antibodies, as we know, are not tested as a routine thing, because in conventional medicine, it doesn't change the management. Whereas obviously we know that's not the case at all. So the earlier we can pick it up, and I think if there is a suspicion of someone could have hypothyroid, and given that most cases are Hashimoto's and or are autoimmune, I do test them, because the earlier we can pick it up, then we can address the factors and just keep things at bay and start to improve things. Because if that's left over months and years, it can get to a point where there's been enough atrophy of the thyroid gland, there's enough destruction of the thyroid gland, such that then, yes, people will probably need to take thyroxine and or T3. Whereas if you pick it up in the earlier stages, we've got a chance to really say, okay, where's this inflammation and oxidative stress coming from, and let's try and address this.
How does your treatment strategy differ when there's an autoimmune picture? For let's talk about underactive thyroid first.
So again, this is where it's not just about giving thyroxine or medication, which would be the standard route. Yes, obviously it can be important to give some symptom relief, but again, that's not treating the root cause at all. So we have to see, okay, what are the underlying factors in this autoimmune process, which, as we discussed, it's first and foremost addressing all those lifestyle factors. And, we often see, as we go through the history and the whole timeline, that there's been a lot of things happening over someone's life, previous trauma, for example, childhood trauma, the adverse childhood experiences, for example, environmental exposures, other stresses. And it could be one incident, it could be a viral infection, COVID or otherwise, Epstein-Barr virus, the flu, or an emotional event like a bereavement. And then that's just enough to really tip someone over. But yeah, it's important to look at the whole history and think, because often that's when we actually realize, well, actually, this has probably been going on for a long time, but it just wasn't picked up.
And as far as like the treatment options that you use, we've spoken a lot about that today, but is there anything different that you might consider when there is an autoimmune picture, like vitamin D, for example, or anything else?
Yeah, so we definitely want optimal vitamin D levels, so like around 100 to 150 in the blood. And again, this is where the ranges in the bloods are quite narrow, and often someone can have a level of 55 and it's normal, and it's not. We actually want to double that. So yeah, definitely optimizing vitamin D and zinc and selenium, etc., in the bloods. A few other supplements I may use include LDN, for example, low dose naltrexone, which is a compounded medication. Again, it's not first line; we do everything else first. But that is one I do use, and studies have shown, and I've found as well, that it can help to reduce the antibodies. It can really just help to modulate the immune system. And there's also research in it helping with, say, fibromyalgia, rheumatoid arthritis, and other autoimmune conditions as well. So again, it's compounded, and we start at a lower dose. May even start with sort of 400 micrograms, 1 milligram, and then you can go up to about 4.5 milligrams for that.
And what about the overactive thyroid picture? Obviously, we don't see that as much, but is this fair to say that there's not as much we can do, I guess, naturally compared to for hypothyroid, or is that not right?
No, I'd say there's definitely a lot that can be done from a lifestyle point of view. I would say a lot of the principles, I would say, still apply in terms of, the diet we know can help with Graves as well, in terms of helping with the antibodies. And obviously, again, given that it's autoimmune and most of the immune system is in the gut, still looking at the gut and improving the gut dysbiosis, etc. Leaky gut is definitely still relevant, as is obviously stress management and sleep hygiene as well. So I still look at all those lifestyle factors, and even with nutrients, like we know selenium has been shown to reduce the TSH receptor antibodies as well. So yeah, I would say there's a lot that still can be done.
Would you go to medication for those patients more often than you would for the underactive thyroid patients?
No. Often people are already on it and they want to come off it. And it's more guiding them to reduce the dose. And what we find is that as we address all the lifestyle, as we address everything from a functional medicine perspective, over time, we can reduce their carbimazole.
Yes.
So again, we do that very, very slowly and gradually while we're monitoring the thyroid function as well. And many patients have at least been able to reduce their dose of the carbimazole, if not stop it altogether.
Byron Pugh is a 50-year-old mum of two who recalls with regret her story with Graves' disease.
So after the birth of my daughter, I was very, very anxious. I was hot all the time. I was losing a lot of weight and just didn't feel right. But sort of, I think having a newborn and being, really OCD, probably I just dismissed the symptoms. And it wasn't until I went in to see my doctor with a skin rash on my face that she said, "You look really unwell. You just look really unwell, and let's get some blood tests done." And that's when it came out that was the problem. I got diagnosed with Graves' disease. So I think my daughter was probably 10 months, maybe 9 months. So I then discovered that pregnancy can trigger an overactive thyroid, and it can become Graves' disease. So they popped me straight on medication. But I was really struggling, and I just didn't even consider that it was something like a medical condition. I just thought, we thought it was postnatal depression or any of those things.
And when you say you were really struggling, was it the anxiety? Was it what was
The anxiety was the biggest thing. I didn't trust my husband with my daughter. I didn't trust anyone with my daughter except me. She wouldn't sleep. She wouldn't feed. That was making me crazy. I couldn't sleep. And now I understand that it was because of my Graves' disease, because of my thyroid. And then I subsequently realised that I couldn't sleep because having Graves' disease or an overactive thyroid meant that my body was running a marathon the whole time, and it just meant that I couldn't sleep. It was like literally impossible for me to sleep. And I was hot. I was eating so much food, enough for a football team, and I was losing weight. I was seeing a personal trainer, and I thought, oh gosh, she's fantastic. I'm eating chocolate muffins and bratwurst at the markets, and I'm losing weight. It's fantastic. She's personal trainer's amazing. Yeah, no, I had a medical condition. So, fun times.
And so you went to the doctor. The doctor said you look unwell. She did some blood tests with you, determined that you had Graves' disease, put you on medication. And so what happened when you went on the medication as far as your symptoms were concerned?
Well, they did. I was actually pregnant with my second child. So the endocrinologist was very worried about me losing the baby because I was so thyroid toxic. I was on a really high dose of PTU. My symptoms, pregnancy also helps your Graves' disease sort of go into remission, from my understanding. So things settled down and we had our second child and he was fine. We tested him. And then I was on medication for another 12 months and things settled down. I started to feel normal and I went into remission and that was great. Then it came back. So went back on medication for 12 months. We moved countries. It came back. And I could tell, like I started to know my body. I knew when things weren't right. And I knew when I started to feel like I was ramping up or I'd get really shaky, I couldn't function properly. I would start to get very anxious. At one point, my thyroid gland started to swell and I actually had a noticeable, to me, goiter. And my eye was wonky. My left eye, my right eye was wonky, which I think it still is, but other people don't notice. So then I think I stopped taking the medication in 2020 and I now haven't been on medication for almost 2 years. And I feel fine, which is really bizarre. I think I'm in remission.
Do you notice that anything, like you've mentioned a couple of times, like you moved countries, it came back. Is it the stress that kind of brings it back for you?
I'd say absolutely. Absolutely. Moving countries was the first time with very young children was enormously stressful. And I think that is probably what triggered it again. I also think there's a fair bit to do with diet. I know that a lot of medical practitioners aren't behind that, but I do think we are a product of what we eat. And I think perhaps some of the food in America wasn't, particularly healthy. So even though we ate organic and I got eggs straight from the farm, I got, low temperature pasteurized milk. I was really, really fanatical about the food. I don't know. I feel now that we've moved countries again, we moved here in 21, I think. And I got tested when I got here and my levels were fine. And I haven't been back to the doctor because I haven't felt sick. And, I'm active. I don't have any issue with strength. I don't have any issue with, staying fit. I know a lot of people with Graves' disease, often can't get out of bed. They feel so terrible. That's never really been the case. But I do think the diet, like having a good diet, clean diet does help. And just trying to be as active as possible.
Is there anything else that you do that you on a daily basis that you think helps to manage it or to stay in remission?
I think the stress thing and knowing that I've got support at home where if I wanted to go back to full-time work, that'd be great. And my husband would be like, do whatever you want. That's terrific. But if I don't feel that I can manage that, he's also okay with that. And knowing that he's okay with that takes the pressure off. I feel very fortunate that, we don't have to be a double income family right now. And that takes the pressure off. Whereas in America, I definitely felt like, well, I need to be working. I need to be bringing in an income. That's really important. So I think that put a lot of pressure on the family unit and probably contributed to the Graves' disease rearing its head sort of periodically after every 12 months or so. Whereas over here, there's just not that pressure. So it's like, okay, I don't have to worry about that. That's something I can sort of put to the side and just enjoy parenting and, being a Stepford wife, as it were. As much as I hate that term, and I do feel kind of guilty and also a little bit not mentally challenged, not really working full time. It is very weird. But it's also nice to know that the pressure is certainly not there. Which probably helps with the Graves' disease, I would say. Because, it never goes away. It just goes into remission.
Is there any kind of advice that you would give to patients?
Seek help immediately. I was fortunate that I had a good relationship with my doctor. She knew me. She'd been my doctor for a number of years. She could tell just by looking at me that I was unwell. Find the right endocrinologist. Don't be afraid to say, you're not working for me, and find another endocrinologist if you can. The second endocrinologist I had just was not the right fit for me, and I found someone who was fantastic and very supportive. So I think try and listen to your body. You don't let people fob you off. I was told it's just postnatal depression. I wasn't depressed. I knew I wasn't depressed. I was crying all the time, but I was not depressed. I just couldn't, I couldn't cope. The thought of taking my baby out to a restaurant in a stroller would undo me. The thought of being left alone with my child all day was terrifying, and by about 4 o'clock, I would have to ring my husband and say, you need to be here. I can't do this. It was a very, very, looking back on it now, it was a very, very dark period of our relationship. And I feel that this condition robbed me of the first 12 months of joy with my daughter. I feel to me, that's had longer term ramifications, in how our relationship developed, because I could not enjoy her first 12 months. I was so mentally crazy with anxiety, and it was like I was a strung out junkie. I don't know what that feels like, but to me, if that's what it feels like, I wouldn't wish that on anyone. It was horrible. So go and see a doctor straight away as soon as you don't feel well. Don't be afraid to speak up.
In the next episode of Between Clinical Minds, we continue the conversation on autoimmune thyroid conditions, this time with integrative GPs Dr. Charlotte Middleton and Dr. Aparna Hegde and clinical pharmacist James Jensen. Thank you for listening. We hope this podcast engaged and empowered you. And thank you to all of our experts. You can read more information on each of them on our website, bioconceptsengage.com.au. If you enjoyed this episode of Between Clinical Minds, please refer a friend and share the love. To continue the conversation, you can contact us at bioconceptsengage.com.au, where community is more than a concept.